Now, I'm formally inviting Dr. Susan to inaugurate the session and say a few words. Over to ma'am.
Good afternoon, all. Thank you for joining us for this two-day webinar on management of learning disorders. We have been overwhelmed and humbled by the massive response that has been actually to the webinar. We've had over 700 registrations, and it just shows how much people desire to know about learning disability and desirous of how to help the
Ma'am, you are on mute, ma'am. Yes, thank you.
Thank you. So today we are having a session primarily to discuss how exactly do we diagnose learning disability and how is the brain different in these children with learning disability, plus the various other features that are there associated with learning disability. So these are the three topics that we'll be covering today. Tomorrow, we'll be covering the management as to what do you do, how can you help these children. Now, this webinar was actually conceived with the idea of helping teachers to identify and to help the children in their classes. And over 50% of our registrations are teachers, but we do have a lot of professionals as well as parents who are joining in. And so even though this webinar is going to be primarily targeted at teachers, we do hope that we will be able to answer most of the questions that you have in your mind. And in addition to that, if there are any other questions, do let us know in the chat box and we will get back to you on those. So without much ado, I welcome you all again to this webinar, and I hope you will have a good learning experience these 2 days. Thank you.
Thank you, ma'am. Now I invite Ms. Ambali Vijayaraghavan. She's a Chief Operating Officer at Astra Medicity to say a few words and facilitate the gathering. Over to you, ma'am.
Thank you very much. Good afternoon, everyone. I'm actually really happy that I could be a part of this event today. I have a young girl, and I often feel that, as a parent, sometimes have I been a little bit too hard on her as far as her studies and her academics are concerned. Doing a bit of research for this particular event today, I realized that, when we were in school, we were sort of typecast into children who studied well and who did not study well. And I wonder if there were children amongst us who actually had a learning disability and who could have been helped, and with that help, whether they could have overcome their difficulties in subjects or in some areas. I really hope that we are able to put out specific action points for people who are listening in today and hopefully make a change in the life of children with learning disorders. Statistically, I believe that learning disabilities are seen in around 10% of all children. And whereas they have normal intelligence, they may have difficulties in these little areas. But I mean, the society is such that they get sort of typecast as children with or without intelligence. And I really hope that the true potential of these children gets realized through sessions such as this, and they have a better chance at being stars. People like Albert Einstein and Thomas Edison, Pablo Picasso, these are stars who perhaps had learning disabilities at some point in time. And I hope that we are able to help children and achieve their true potential. Thank you so much for the trainers today, the speakers who will actually be throwing light on this subject. Over to you. Dr. Susan?
Yeah. Thank you, ma'am. So it's my honor and privilege to introduce Dr. Jason, Senior Associate Consultant and Head of Pediatrics Department in Aster Medcity. He is a veteran pediatrician with more than 36 years of experience, and he's one of the most respected personalities in the pediatric healthcare fraternity, with his areas of special interest, including LD, developmental pediatrics, and life skills training. Sir has been the national convener for the IAP post-scholastic performance, and he's been the past secretary and president of IAP and NNF Kerala State Branch. The immediate past chairperson of IAP Neurodevelopmental Chapter. He's a resource person and master trainer for various IAP action plans. He's authored a book on life skills, formulated a community-based program for children with learning disability, and so has authored chapters to various pediatric textbooks. He's been the reviewer of various pediatric journals and textbooks. And Dr. Jason sir has published 80 articles in national and international peer-reviewed journals. And sir is the brain behind the IAP drug formulary that's considered the Bible of pediatric drug information and used by pediatricians worldwide. I invite you, sir, to deliver this presentation. We are waiting for your presentation.
Thank you, Maria. Good evening, good afternoon to everybody. It's great to be part of this session because we have been passionate as part of the IAP Neurodevelopmental Chapter to propagate the idea of management of post-scholastic performance in children. So I give a pediatrician's perspective about learning disability. We've been working with learning disabled children for the last 25 to 26 years. And in the IAP, that is Indian Academy of Pediatrics, the pediatricians have been trained all over India. We've had a lot of workshops for parents, for teachers and all that. And so this is something that we are very passionate about. We have been doing some advocacy. We have got the learning disability included in the Persons with Disability Act. It was not there initially. The new act that came in last year. We were instrumental in having this disability because it's an invisible disability and it's very difficult for us to assess the range of difficulty, and therefore it was not included. Now we've included it as part of the PWD Act. I will start this session by telling you, see, these are frequently asked questions regarding learning disability. There's a lot of questions that parents and teachers have, because all of us, want our children to become either doctors or engineers and do very well in studies. And if they don't do well in studies, it's a big shock for a lot of parents. And therefore, we need to allay those fears and be able to walk these children through their lives. The first thing that we'd like to mention is that the premise with which we deal with children with learning disability or learning problems is that no child performs poorly in studies on purpose. Can we this thing that minus that so that I can see the whole slide? So that is the premise with which we approach a child with learning problems. Therefore, yeah, so that's so any child with a learning problem needs an investigation. That is the crux of the matter. We need to find out what the underlying cause is. Now, what is the most common cause of learning disorders in India? Now, this is a case which I wanted to share with you. It's an 9.5-year-old boy. He was not doing well in studies. He failed in social studies, and he had just about poor marks in almost all the other subjects. He's not at all interested in studies, always playing and stubborn, and wanted to get everything that he desired immediately. Father was a businessman, lots of money. Mother studied only up to 8th standard, watching only serials, does not read, and is unable to help upend in his studies. Father feels that when he grows up, he's joined the business. Why should he study? Money was given to him in plenty as pocket money, and all that he's asked for was provided. So this is a condition, this is one of the situations where a very rich family, business people, where there is no learning environment. The lack of learning environment is the most common cause for learning disorders in children. So when you see a child with a learning problem, we'd like to check out what his home situation is like. If there's an illiterate parent or the mother is a man laborers, they're not fluent in the medium that's being taught in school, or the father's in the Gulf and working out of station and the mother's too hard-pressed to attend to the child, or they're not seeing meaningful TV programs, not going to the library, not reading. So these are issues which create an environment at home where there is no need to study. That environment is lacking. And the NDP, or the no detention policy, the education policy that was followed till recently because of RTE, that's the right for education, saw to it that there was no exams, and these children were passing till class 9, class 8 without an exam. So what does it need to study? Even if you don't study, you're going to pass on the next class. The teachers don't need to teach because they don't find the motivation to teach, because anyway there's no teaching required, the children are passing. So therefore, it is found that in many schools, in children in class 7 or 8 had only the writing ability or the maths ability for class standard 2. So this is a problem with a no detention policy. And I think recently NCERT had seen to it that we have at least 2 exams at 5th standard and 8th standard. It is a proficiency test sort of thing, aptitude test like thing, but at least something to ensure that there is some learning happening and there is some sort of teaching going on, so that you can assess these children as far as they're, because you would not detect a child with learning disability. Learning problems, what a child presents with is poor marks, and poor marks is like cold and cough. It's like a symptom. So if you don't get poor marks, how do you recognize that the child is not doing well? So the detection of learning problems also would be hampered if there's no detention policy. These are issues which need to be corrected. So the take-home message is case 1 is that it's extremely difficult to manage a child with an environment that's poor. There's no learning environment at home or in school. So study habits are difficult to inculcate. It's very difficult, as you'll all agree, to change behavior of a family. If a family is used to not reading and seeing nonsensical serials all the time, it is very difficult to change behavior. So behavior is change, skill change, and mental status of which families are almost impossible to change. So if you have a child in this situation, even a normal child would not be able to study well. So what would be the status of a child who has a learning problem? So that is that's a red flag sign as far as I'm concerned, where there's no learning environment in school or motivation to learn at home. That is a situation which we must be aware of. The second case I'm put up is Chinnu, is a 2.5 years old, who's clumsy and not able to jump, speaks 2 to 3 words at 2.5 years, and does an activity repeatedly, falls while climbing steps. So she's clumsy. So there's some coordination problems, and there is a speech delay. So this child has been referred for assessing a child if the child is at risk for specific learning disability. Now, the early indicators of learning disability are, the most significant early indicator of learning disability is speech language delay. So if a child is not speaking the first 1 word with meaning by 1 year, if he's not saying about 5 to 7 words with meaning, meaning if he says calls Amma, he must be calling Amma, only Amma. He can't be calling everybody Amma. That means he doesn't know the word, what the meaning of the word is. And there should be a reason for calling. So if he says Amma, for Amma to come close to him, that means he knows the word Amma. So that way, if he says if he doesn't say 1 word by 1 year, if he doesn't say about 5 to 7 words by about 1.5 years, and is not saying about 50 to 70 words with meaning by 2 years, and not making a 2-word sentence by then, he needs assessment. That is the most early indicator of learning problem, because the basis of learning is language. When we are reading, or we are understanding what we're reading, or we are applying what we've read with knowledge that we have, our brain is working in the language that we're most proficient in. So if there is a language delay, that child is going to have a learning problem sometime in his life. So late talkers is a significant early indicator of specific learning disability. Now, there are other early indicators, but the most significant is speech and language delay. Therefore, if you have a child who's having a slight delay in the first thing, intervention, early intervention, for any disability, the crux of treatment is in early detection, early intervention, and the third is working on strengths. So these are the principles of managing any child, differently able child. So here also that matters. So if you pick up a learning disability, speech delay, never tell the parent or that this child will talk, because in the family, everyone is talk a little late, so it doesn't matter. If you miss out at that point, then you might get this child at class 3 or 4 when he's having a lot of problems with learning and you miss the bus. So therefore, early indicators are so important. So what are they looking for in speech development? Pronunciation problems, difficulty learning new words, slow vocabulary growth, difficulty finding the right word to use when speaking, difficulty understanding simple one-step directions, difficulty understanding questions, difficulty recognizing or learning rhyming words, lack of interest in storytelling and immature grammar. So these are all things that you could pick up in a small child when as a child is learning to speak. The other things would be left, right. So if a child at 4 years asks, after he's gone to the bathroom and had his motion, asks which is my right hand to wash his bum, that is an indicator that this child doesn't know what is right and left. Understanding what is up and down, or below and top, or small and big. These are all things which you could pick up in a child who is delayed, and therefore these are all early indicators which we must look for. A child who doesn't crawl is sometimes, some children don't crawl at all. So that means the coordination between the right and left brain is may not be effective. There are children who don't crawl, but it doesn't matter. But these are all something soft signs which we must look for. The third case, I'm talking about an 8.5-year-old Danesh who was brought for poor school performance. He was getting very good marks up to class 2, deterioration since then. He's very good, knows all the serials, films, very good at music, interpersonal relationship and extracurricular activities and computers. But when it comes to study, he avoids writing, prefers to read, prefers to be read to. There's atrocious spelling, and there's excessive TV viewing, and he's very good at maths. He prefers to spend all his time doing his maths homework. So what is this? This is a classical history of a child with learning disability. A child who's doing extremely well in class, LKG, UKG, is a topper, is the most sought after because he's an excellent child. He's very good at he's got a lot of talent. But when it comes to studies, when it comes to writing, their problems start. And this child suddenly starts deteriorating in class 1 and 2. That's a classical history, because the brain is normal and the brain is able to overcome some of the defects that he has. As the learning becomes a little more difficult, the problems start. And we call it specific learning disability because only some areas of his brain are affected. So there are a lot of areas in the brain, left and right side of the brain, which are required for learning. And if any one of them, I explain it like an electricity in the house. There are so many gadgets working on electricity. For one bulb is fused, that's the only portion that is not working in the house. So that is how a learning disabled child. So a learning disabled child, all these areas are connected by nerves. You can imagine it that they're connected by nerves. And if one of those nerves are not working, if he has a problem with numbers, then he's going to have a problem with maths. But his learning, as far as his language and his spelling and all, is very good. If he has a problem in his language area, then he may be good at maths. Still, language becomes important for when he's answering questions. So therefore, this is an area. So why do we need to recognize these children? The other clues that you think about is refusal to read or write. Why should a child, every child wants to be thought of as the best thing in the world. If he refuses to read, probably has a reading problem. If he refuses to write, probably has a writing problem. So a child who in LKG doesn't like to write, and you scold him and try and punish him for not doing it, you're actually doing harm to this child because you're not recognizing that he has a problem. Why should anybody refuse to do things? If he has a problem, if it's easy for him to do, he'd do it. Anything that you have difficulty with, you would avoid. If you're good at something, you'd have no problem doing it. So if there's a refusal to read or a refusal to write, probably he has a problem in that area. Tiredness after school, because the mental effort required to read and write and learn is so much that physically they get tired after school. So tiredness after school is something that rings the bell that probably the child has a problem with learning. Psychosomatic symptoms. Anxiety is a common problem, comorbid condition with learning disability. So a lot of these psychosomatic, central abdominal pain, children who suddenly come off pain, saying they have stomach pain, central abdominal, near the umbilicus, little while runs around, you just touch the abdomen, he runs and plays, then he comes again, because 10, 15 times a day, he'll say central abdominal pain. Most often it is anxiety. It's like, when you're not prepared for exam or you're not prepared for an interview, you have butterflies in the stomach. That's what the children feel. They feel like there is something happening in the stomach. So that's central abdominal pain because of anxiety. Nail biting, frequent micturition. 10 times a day they go to the bathroom, come back. There's no pain when passing, but a little bit of urine passes, comes back, goes again. Titubation, slowing movements of the neck, blinking, frequent blinking, or sighing. Sighing most likely in the older children. When they sigh frequently, it's probably the brain. The brain is making a joker out of them. It makes you do things because of your anxiety. So these are psychosomatic symptoms which give you a clue that probably there is anxiety, and anxiety most often, the stress most often in children is school. There's so much to read, there's so much of competition. So school is a very, very stressful area for children. And therefore, psychosomatic symptoms should alert a person to the possibility of a learning problem. And this should be assessed. So you do an educational history, you'd ask whether there's any adequate opportunities and facilities to learn at home. What are the reading skills, storytelling, listening skills, handwriting and grip. You'd find that LKG, UKG, if they're holding their pen in a very awkward position and using a lot of pressure on the paper when writing, probably has a problem with writing. So therefore, early intervention would be to teach fine motor skills. You could use the dough, the chapati dough to, he can play with that plasticine, or he could use something small craft work so that the fingers of the hands are used more frequently. So those sort of exercises can be started in the children to improve their hand grip. There are certain gadgets also we can use on the pencil to improve hand grip. So these are things, early intervention is possible in all these areas. So the early distractibility and importance the child and the family gives to exam results are all things that we need to look into. Every child with a learning problem, you must look for the sensory inputs, because vision and hearing is absolutely essential. Every child with a learning problem must check whether his vision and hearing is okay. Thyroid must be checked. Usually you have a thyroid check at birth, but if a child is suddenly deteriorating in studies, you must check his thyroid whether there's a problem there. But vision and hearing is a must. Every child should be checked for vision and hearing, because mild hearing and vision problems which you might not recognize may be a reason why the child is not doing well in class. Dysmorphic features, smile, soft neurological signs are things that we pick up. Coordination problems, like we already mentioned, that can affect his learning. And check if there's any medication that is affecting his attention span. So samples of his writing, we look at his homework, we look at his notebooks, we look at answer papers. These will give you a clue because the mistakes a child with learning disability does often repeats itself. He repeats the same mistakes again and again because his brain can't understand what the mistakes that he's making. So if he writes something and he checks again 10 times also, he would not realize that he's made a mistake because his brain has not recognized. A child who recognizes 6 as 9. If he can't see 6 as 6, he sees it at 9, he can never correct it unless a remediation happens. The repeated monotonous effort to make sure that he's making a mistake when he writes 6. It requires a lot of effort. It's a monotonous process by which, with a lot of cards and all that, the child is given the clue that he's making a mistake. Only then he can recognize it. Chronic illnesses also must be checked out. So therefore, sensory inputs must be checked in all children having learning problems. So why do we need to recognize specific learning disability early? Now, this is another question it's a neurodevelopmental problem. We must realize that a lot of children, a lot of parents have realized that when the child starts performing poorly in class, there's a blame game going on. The mother blames the father for not being there. The father blames the mother for not teaching properly, and there's a big problem at home, this marital discord. There are parents who have gone to the brink of divorce. And then you've recognized this child has got learning disability and told them this is not your problem. This is not your fault. Don't feel guilty. This is a problem that the child has in his brain. It's a neurodevelopmental problem. They get together. Because if you have a child with a intellectually impaired child, parents usually get together and help this child. But learned disability is an invisible disability. They don't realize this child is a problem. So unless you recognize it and then tell them this is a neurodevelopmental problem, it's not your fault, it helps. So IQ is above average or above average. And early detection, therefore, is so important because these children are trainable. These children can be made useful citizens of society. So that's why you must recognize specific learning disability early. A global delay, you must differentiate between a global delay, meaning that the child has got delayed his problems in all areas of learning. His executive functions are also poor. So there it is very difficult to teach this child. Slow learner, it's very difficult to impart remedial education because there's a lot of stuff that you need to teach these children. And you need to teach them early, get them early, because at age stage, right from the beginning, the remediation starts. Only then, if every passing year, new remedial methods can be added on. So if you get a child at 10th standard, if you recognize a learning disability, you have missed the bus. So early detection and early intervention helps, like I said, for every, and working on strengths is most important. So when a child with learning disability you find that he's very good at music or he's very good at sports, the tendency of the parent is to stop him from doing it because he's not learning well. So that's something that should not happen. If he has strengths, it should be encouraged. And if parents can recognize a strength, or anybody working with a differently able child, the one thing that every professional or every parent or every teacher dealing with children must find out what they're good at and must encourage that to the maximum. So if he's good at studies, if he's good at music, and he performs really well at music, that improves his self-esteem. Self-esteem, as soon as self-esteem improves, there is all-round improvement in performance. Even studies can improve. So therefore, working on strengths is most important. Finding those strengths is also a part of our. So if you don't get these children early, you miss the bus. As I already said, if you diagnose late, it's very difficult to institute any remediation. The fourth case is Pavitran, is a 9th standard child at 14 years, sudden decline of scholastic performance for the last 1 year. Disturbed sleep, sighing frequently, increased palmar sweating and writing. So when there's palmar sweating and when writing and there is unable to concentrate, probably anxiety is causing it. Sighing, as we already said, is a manifestation of anxiety. Taking a deep breath once in a while and suddenly saying that he can't get breath. These are all symptoms of anxiety. Disturbed sleep, unable to concentrate in studies. So he's having an acute problem, an onset of learning problems in the last 1 year in the 9th standard. So what does this imply? This means that it's very unlikely this child has a learning problem. If a child has done extremely well in class 9, and then sudden deterioration means that the chances of learning disability is unlikely. This specific learning disability is a neurodevelopmental problem, so it should have started right from when the child was in class 1, 2. You can't have suddenly a learning disability at that age. So that's something that we must understand. So we must look for events. Tragic events, maybe discord between caretakers, increasing alcohol content, marital discord, substance abuse, sex abuse, exposure to pornography. A lot of children get exposed to the pornographic CD circles, and then they're masturbating all the time. There's children who have asked me, will I have enough sperm left to have children? So that's the amount of distraction that all this can do to your children. It destroys a child, and it's very difficult to pick up these children unless you good counselors. That's why pediatricians are very important, because they are seeing this child from they're very little, and therefore more chance of them, the child being comfortable with pediatricians to tell that this is the problem that he's facing. It takes a lot of counseling expertise to be able to pick up and get these children to admit to these things: sexual abuse, substance abuse, and exposure to pornography. Change medium in school and illness of recent onset should all be considered. Event. The other things, vision and hearing, again, never forget vision and hearing. And another thing we should never forget is depression and anxiety disorder. Depression is something at this age is very common. And if that happens, that can definitely cause a sudden loss of scholastic performance. Convulsive disorder is another thing. So these are things that we must keep in mind when a child suddenly deteriorates in higher classes. Case 5 is a 7-year-old first standard child, second sibling of second of three siblings. He's brought for poor scholastic performance, difficult to teach child. So any child who is difficult to teach probably needs us attention. You know, how we detect these children who have a learning problem is the easiest way is to take the last 10 percentile of your class. If a child is now in the last 10th centile of your marks or performance, that child probably has a learning problem. Because at least 10 to 20% of 10 to 15% of children would have a learning issue, and about half of them would have a specific learning disability. So a child who is difficult to teach must be considered as learning disabled and must be picked up for assessment. Temporarily difficult. Now, this child is restless, fidgety, easily distracted, and all over the place. So this is a child who can easily be recognized because this child has got a hyperactivity syndrome. And this is something that we must recognize as, because if you have a one brain problem, there's a spectrum of diseases, spectrum of disorders can occur. So when a learning disabled child has got a neurodevelopmental issue, has got a problem with the brain, so therefore other brain issues can also happen. So hyperactivity is one of them. And so what we must realize with hyperactivity is that there are three types. One is hyperactivity alone, there is hyperactivity with attention problems, and there's attention deficit alone. Most of them are combined. So when you have a combined attention deficit plus hyperactivity, the amount of time they can concentrate on studies is very little, and therefore it affects their studies a lot. So if they're hyperactive, they're picked up early. If they're not hyperactive, there's only attention deficit, you might not pick up these children because they're very quiet in class. They're not understanding what's happening because their attention span is very short. What we must realize is that the first assessment of these children may not be correct. Because when you're doing an assessment for learning disorders, you're doing probably a Nimans assessment. And when you're doing a Nimans scale, you need concentration to go through. What is done is that for each age, there is a normal amount of learning skills that a child requires for spelling, for writing, for maths and everything. So it is assessed for every age. There is a normal. And if the child is below that, then you call the child having a problem in that particular area of learning. So that requires some concentration to go through that exam. It's like an exam, and the child coming to a center for an exam, there's a little tension for this child. And if he has an attention deficit problem, that first assessment may not be correct. So this child, the IQ was as 90, but it could be better because he had an ADHD. He had an ADHD which is recognized by doing to the DSM-5 criteria. You have impulsivity and hyperactivity. There are criteria for that, and if he fits into that criteria, would we call it ADHD? So if he has an attention deficit hyperactivity disorder, the first assessment may not be right. So after you do a psychoeducational strategies, your behavior therapy, and probably medication if required, then you do a reassessment, and only then you get to know the actual deficits that he has in his learning skills and his IQ. So therefore, the first assessment need not be considered as correct. So the take-home message is that LD is a part of a spectrum of neurodevelopmental disorders. If a child has one, he's likely to have many more. So the comorbid conditions associated with LD, which we have to be aware of and we continuously look for, are ADHD, anxiety disorders, obsessive-compulsive disorders, conduct disorders, depression, opposition-defined behavior tics, and a convulsive disorder. So these are things that may be part of the learning problem with the learning problem. And last case is Sanjeevan, who is a 14-year-old class 9 student receiving remedial education. He was diagnosed with SLD in class 3. And he's regularly getting his remedial education. He had a reading problem and a writing expression problem. Academically successful up to mid-school. Class 9 attended classes, but frequently failed to do work in his class and often did not submit his homework and avoided doing it altogether. His grades started deteriorating, behavioral problems increased. So this is a child who had a learning problem. He was diagnosed as learning disabilities, and remediation started and was treated properly. And class 9 onwards, he started having a problem. There was arguments and fights with the brother very frequently. Parents attempted to set limits, and this caused a lot of problems because he was resisting it vehemently. The home ground became a battleground. And the levels of tension had become so high that it was difficult to manage that house. The parents found it very difficult to manage the children and themselves. There is the role for family counseling. So in family counseling, counseling is very important because the whole family needs to know what each person has, what problem each person has with each other, and understand. They're made to understand what to put themselves in the shoes of the other. And an unbiased, non-judgmental, soothing manner of the counselor helps in satisfying all concerned. You find out what their problem with, and then you give positive solutions for each of those problems, and there's an amicable solution for each of them. So no one is to be blamed for the situation they find themselves in. Actually, it is better that the family does it within the family itself. If that is before involving others in the issues that are happening at home. If the family can do it with prayers, with understanding of the problem, if parents have read about learning disability, know that these children are going to have new behavioral issues that come up as the child becomes an adolescent. So natural history of specific learning disability in adolescence is that as SLD children become adults, a lot of new behavioral patterns start developing in addition to primary disorders. And these behaviors continue into adulthood. So some of these behaviors have the signs of a depressive disorder. So these are things that we must realize that these children are going to go through hell for some time because the amount of effort this child is required through remediation up to class 9 has made him so disgusted with the work. The amount of work he has to do extra to cope with the other students in his class that he has no time for anything else. He comes back home, there's remediation, there is attention, there's behavioral, there's therapy for your ADHD. There's so much more to learn, so much more to cope up with the classroom activities. So he's not enough time. A child who every area of his brain are working properly. Studies is just like easy. He just has to. He understands everything the teacher tells him and he comes in and it's like photographic memory. He just reads through his stuff. Everything is in his mind. So he has a lot of time for extracurricular activities, time for games. A child with specific learning disability doesn't have that. And therefore, these problems will occur. Even a child who's been managed properly, by the time he's in class 10 or 11, is disgusted with this because as an adolescent, these conduct disorders, psychological problems and all that will develop. And the academics, as he becomes an adult, begins to take a backseat. He wants to be thought of as somebody. He may have food fads. He might become a truant. He might do something funny. He might go into bad company because all these children who are not doing well in studies get together, and some of them will have other substance abuse as possible. So a lot of issues can come up at that time. So you need to be really supportive of them, empathize with them, understand what they're going through, because many of these children with learning disability in class 10 and all, they come and cry in front of you, saying that I'm not able to do it. I'm trying my best, but it's not happening. So we must tell these children that it's like the fingerprint of your hands. Every child is unique, and every child God's given a goal. God's given a role in society. None of these learning disability children, if you take care of them properly, some of them are doing much better than the children who have been doing well in class, because the communication skills may be good. So a counselor needs to assess the effect of the specific learning disability on his self-confidence, self-esteem, his perception of how his peers relate and treat him, his feelings of anger, rejection, humiliation, his way that teachers deal with him, the perception of how valued and respected he is by his parents and siblings. And they should continually work on strengths. So if a child, we've had children, this reality shows have been criticized for a lot of things that, because they cause a lot of anxiety in these children. But some of these children with specific learning disability, my children who I've seen over the last 25 years, have made it in life. Was a reality show in which they went for, they realized that they have a skill. And that is the profession that they're doing. There are actors, there are singers, there are sportsmen who are doing extremely well. There are children who have recognized their own strengths. I had a child who at class 12, the school was not allowing him to write his 12th exam because they wanted good results. We had to persuade them to get this child to write the exam. Soon as the exam is over, he went to NID and he was first in the interview. Because there's no academics. It's only creative strength, skills of the child that is assessed. and his creative skills were so good. Most of these children in the night don't even complete their thesis. By the time they're third or fourth year, they get such plush jobs, such good jobs because of their creative abilities that they may not even complete their course. But they're all extremely skilled. And therefore, because of the visual spatial abilities of these children with learning disability, there are a lot of strengths that they have. And this child recognizes his own strength. The parents didn't recognize it. So these are the things that we need to be aware of. So take-home message here is that we need to continue remediation along throughout adolescence and adult life if this child has a learning problem, because there's no cure. If with a severe learning disability, the catch-up is very little, because it's a brain problem, and CNS or the nerves is some area which doesn't regenerate. You must teach them use of gadgets, computers, and calculators, avail of provisions for exams, inform them regarding the NIOS option. NIOS is a National Institute of Open Schooling. And for your information, India is the maximum, there's got a maximum network of National Institute of Open Schooling in the world. And it's an excellent option. Even normal students, I think, should go to this because it makes life so much easier for the children. NIOS is a system where the portions are less, they can choose their subjects, they can write their exam whenever they want, and the certificate doesn't tell you how many attempts this child has taken to pass the exam, class 10 and class 12. And then they teach them about vocational training. So these are a lot of things that you could tell these children when they grow up. So the knowledge of the useful tips in academics and career counseling is absolutely important. Adolescents with learning disability mature a little later than other children and therefore need to be listened to, encouraged, and gently cajoled to keep going. They're slightly late in understanding a lot of things, and therefore empathy is absolutely important with anybody dealing with these children. They have exceptional spatial orientation. So they're very good at 2-dimensional, 3-dimensional visual. So some of these learning disabled children will create websites that are amazing. They create so many blogs and videos that, it's so creative they are that, you surprise this child. He can't write or read, but he does it so well. They're apt for computer jobs, programming, advertising, auto mechanics, artists, designers, interior jobs, creative jobs. Any creative job they're very good at. Those who are very verbal could be lawyers, PROs, salesmen, social workers, receptionist guide, and politicians probably. So, because of their verbal skills, they can be very good at all that. So maybe the only profession maybe to avoid in a severely learning disabled child, maybe avoid medicine, nursing, and pharmacy, because it requires, if any spelling mistakes, you could have a drug might change, you could cause a problem there. So that is one probably. But there are great physicians and people in medicine who are learning disabled. So it's not that you cannot be, but a severe learning disabled child probably should. Secretarial jobs and teaching English or maths may also be difficult job options. So these are them. So career counseling you must know very well, and you must know what the skills of this child are, what his limitations are when you're assessing what profession he can be good at. So in conclusion, again, I'd say no child performs poorly in studies on purpose. That is the premise with which we will deal with all these children with learning problems. You must understand the gamut of issues that these children with learning disability face. Pick up warning signs and early clues, which I've mentioned. Multidisciplinary team should be involved, because it's not, no one person can deal with these children. It requires pediatrician, a development pediatrician, a speech therapist, educational psychologist, like psychiatrist, ophthalmologist, and ENT surgeon. Everybody should be involved in, whatever problems the child has should be dealt with, and they should detect them early, and this should be supervised or by a pediatrician or development pediatrician who sets goals and monitors progress. So holding this child's hands make life easier and less stressful while imparting life skill training. Life skill training is very important for these children, and because there's awareness, self-awareness and self-esteem should improve. Their problem-solving techniques should be good. So there's a lot of things that communication skills can be improved. So these are life skills training can do a lot of good for these children and engage in making each of them a useful citizen of society. Thank you so much.
That was an excellent presentation, sir, with wonderful case examples and guidance for early identification of learning disability and special suggestions for parents for helping their children in being what they're supposed to achieve in life. So next we have Dr. Basi Sukumaran, sir, Professor and Head of Department of Clinical Psychology, SRM Medical College, Chennai. We are honored to have you, sir, to know about the neurodevelopmental aspects and the brain in learning disability. He's done his PhD in clinical psychology and MPhil in clinical psychology from the Department of Clinical Psychology in IMANS, Bangalore. And sir has been certified EMDR therapist, and he's Pearson qualified Cogmet coach, which is a computer-based remediation programs to help improving working memory. And Dr. Basi is also trained in solution-focused brief therapy. We are honored to have you, sir. Over to you.
Am I audible?
Yes, sir. Yes, sir.
Are you getting my screen share?
Yes, sir.
Yeah. Okay, then at the outset, thanks a lot. Thank you very much for inviting me over for this talk. And I feel quite honored to share the platform with stalwarts like Dr. Jason Unni and Dr. Susan Sakaria. I hope that I will be able to do justice to the responsibility given to me. The topic I am taking today for presentation will be talking about the brain in a learning disabled child. What is the role of the brain and what we know from cognitive neuropsychology about what happens. So the overview of my presentation will be as follows. I will...
Sir, can you put it as a slideshow, sir?
Yeah, just 1 minute. Yeah, are you getting the slideshow now?
Yes, sir.
Yes.
Yeah.
In
So
Telugu,
the
sir.
overview will be, I'll be giving you a brief historical tour about how knowledge about various concepts in learning disability have developed. And I'll talk to you about the influence of cognitive neuroscience and the various concepts that they have put in forth. Then some brain facts, some genetic facts, and then the cognitive correlates and the implications of this, how this translates to intervention per se. Are my slides moving along? Are you getting the
Yes,
next
sir.
slide? Yeah.
Yes, sir. Yes, sir.
Okay. So historically, neuropsychological research focused on tests to identify brain dysfunction, try to identify the possible neural mechanisms that are there, and try to underlie to this what would serve as a basis for remediation. Most of the neuropsychological research for the last 50 years has been more on reading disabilities or dyslexia. There's some work that is being done on dyscalculia also, but most of the work is being done. Now, historically, if you look in 1895, Hinchelwood introduced the word blindness to describe non-brain injured children who had word difficulty. And then dyslexia was introduced by Orton in 1928, again to identify children who had difficulties in reading and spelling. And he attributed it to a disordered cerebral dominance for language. So early itself, the role of the brain in this function has been identified, even though they were not able to give you more information about that. Learning disabilities was introduced by Kirk. He gets the honor of introducing the term learning disability. And he differentiated learning disabilities from intellectual disabilities or developmental delays that are there. Assessment was mainly the function for trying to identify learning disabilities and then identifying the different profiles that you see in the pattern of tests that are administered and try to identify the subtypes. So Benton in 1975 identified various neuropsychological correlates, the most important of which are phygnoragnosia, right-left confusion, auditory visual integration problems, color naming problems, etc., which remind us of what Gersman in 1924 talked about, where he described the Gersman syndrome as acalculia, fingeragnosia, right-left disorientation, and agraphia. So even though the Gersman syndrome has been disputed at different levels, you can see that most of the deficits that he had identified are still present. Then we come to 70s where they hypothesize parietal lobe involvement that could be maturational in concept, but not a developmental Gersman syndrome. Then other uh, scientists try to identify and say about the fact that no, it is more due to a maturational lag. This was contested by other people because Rook showed that the neuropsychological deficits persisted. So you can't say that it is a delay in the brain development, because if it is a delay, then there should not be any persisting deficits that are there. So then the whole attribution said was more focusing towards language problems. There's a basic problem in learning disability is a problem with language. And this is the view that is prevailing now also, that is more a language processing deficit that is seen, which is the underlying cause of the learning problems. So a lot of subtypes were identified. Research was more focusing on trying to find the profiles in neuropsychological tests, trying to understand better the causes of LD. And so this led to a lot of changes in the way learning disability was viewed, and also the importance of IQ. IQ was not considered as a big factor in explaining learning disability. And the most important fact was the theory of speech processing that Lieberman and his colleagues initiated, where processing as a phonological representations. That is how speech processing does happen and how these phonological representations are identified. So subsequent linkage of awareness of phonological skills was considered to be the basis of development of word recognition or reading skills. So this is the first uh, initial shift in the direction towards focusing on language and language processing and phonological awareness. Now, phonological awareness is more considered to be a metacognitive ability. It's sort of an ability that you are aware of the sound structure of speech, the different sounds of different words, and the different variations that occur. So, for example, when I started working in learning disability and trying to do intervention studies, I came to realize the complexity of language and language processing. For example, if I put the word PIN, you will all be able to read it as pin. And if I put it as PINE, you will read it as spine. But here what happens is that the sound for I changes with a certain rule. This is called the last letter E rule, where the sound of the vowel changes with that. We have all learned to do this without any effort. I never knew that there was a final letter E rule that changes the sound, but I was able to read all these words without any difficulty. So this problem with children with learning disability lies in this, that they are not able to decipher these changes. They are not able to identify the sounds that are there for different letters and also the changes that occur over a period of time. So they are sort of rigid in their understanding of that. And this basic phonological awareness is considered to be the basis of all learning disabilities. So to read, you must understand the orthographic patterns. Orthographic is just a fancy word for the structure, your alphabet. So your different scripts. So you have Malayalam, you have English, you have Hindi, you have Tamil. So the child must link the way the alphabet is written to the sound, the internal structure or the sound of that. So first, that's what we learn. A for apple, B for bat is how we start learning. And now when you go with a phonological or alphabetic principle, they will say they will teach a, ba, ka, da instead of a, b, c, d, because these are the basic phonemes that are linked with the alphabets. Now, alphabets are funny in nature. They can be opaque and transparent. So when you look at the orthography, orthography is the script. The script can be opaque in the sense that the same sound can be represented, different sounds can be represented by the same word. It is not a literal translation of the words. The words change sound when they get combined. Whereas a transparent script, like most of the Indian scripts, Malayalam, Tamil, etc., when you write Shah, you say Shah. So there are no two different ways of writing that. So this is a transparent script. So the alphabetic principle is also verified across both transparent and opaque scripts also. So this is very important for the learning of this, because this is where the first we have identified a specific cognitive skill, that is awareness of sounds, phonological awareness, that is linked to a decoding skill. Or what is the decoding that is there? Linking the sound to the letter. You are decoding that. When you see a letter, you are supposed to say a sound. So that is a reading skill. That is the academic skill. So this is where the first link has been made, and the same uh, cognitive the thing is helping you to be successful in reading, and if the deficits in that leads to failure in reading. And academic skills, like all the teachers know, are dimensional. No two children have the same achievement level at any level, even though the inputs given to them are the same. The same teacher comes to the class, the same teacher teaches the same portion, but the achievements of the children are dimensional. So there's a lot of normal variation in this. So there are complex traits that are seen. And how do you differentiate learning disabilities in academic domain? So there's a lot of research that is there. It is replicable, and the cognitive processes are identified in that. So 6 domains of learning disability now have been identified. At the reading level, you have a word identification and reading comprehension. In arithmetic, you have computational problems or difficulties with applying the addition subtraction principles, and you have procedural problems that involve problem solving. And at writing, you have problems at transcription, whereas the basic handwriting is there. And you also have dysgraphia, where they have difficulty in generating the text, writing, composing an essay and writing that. So at 2 levels, you find that the basic problem, word recognition, can interfere with word comprehension. Computation, or ability to add and subtract, can interfere with problem solving. And handwriting, or the what do you call, dysgraphia, can also interfere with your text generation or your productivity at uh, creating answers and solutions. So now when we look at neural features, there are a lot of advances that are there in imaging strategies which have helped us quite a lot. And most of the studies again are on dyslexia, but they have identified 3 left hemisphere regions that are largely supporting proficient reading. And these are impaired in people with even problems at word level disorders also, not just reading disorders. So there's to be, I'll just go through it a little faster, so that one is for time constraints and other is to simplify it a little bit. So you have a ventral stream that involves the occipital regions or the posterior regions of the brain, a dorsal stream that involves more the middle regions of the posterior temporal gyri and the regions of the parietal lobe. And there is part of the frontal regions that are involved, inferior frontal regions are involved. So there are 2 streams that are there. So if you look at this diagram, you can see the dorsal stream is identified by the blue lines and the arrows that go. The ventral stream is linked by the red colored ones. So there are 2 streams that are there, and these 2 streams are considered to be involved in all your language processing. The 2 dark circle-like areas, circular areas are there. The one in the towards the right is the Wernicke's area, which is the parietal areas, and the one in the towards the left represents more the area where speech production is being done. So you see that there are two streams that connect to these areas, and this network does not develop without showing the child alphabets. For illiterate people, this network does not develop. And so they are based on evolutionary based networks for language and visual processing. And this is what basically allows extraction of language from vision. So when we work with people who have got problems in language and comprehension after head injury, after a stroke, etc., we find that they are unable to read, but they are able to match pictures to words without being able to read the word or even say the name of the picture that is shown. So there are different modalities that develop. So the modular aspect of language is what is emphasized in that. So the dorsal stream is more associated with the word meaning, and the ventral stream is more associated with the script reading. And the ventral stream is highly dependent on its exposure to print, to alphabets, to books, to written material. Word form area that mediates the immediate word recognition. So that is what it is considered. And this network is universal. Despite what language you look at, you find the same networks that are being seen. The most earliest identified difference is in the temporal planale. If you look at the greenish colored regions, I don't know, somehow my cursor is coming. If you see on the left temporal lobe, the green area is bigger compared to the size in the, this is the, what you call asymmetry that is seen in every normal individual, that your left temporal lobe, the temporal planale is larger. This asymmetry is not seen in children with learning disabilities. Autopsy studies show a very clear brain basis also for that. Now, if you look at genetic factors, you find a large prevalence of that. I think the figures are not very important, but among 90% can be attributed towards this learning disability. Then there are chromosomes that have been identified. I myself do not know more about these chromosomes. This is just for information, and information is available for anyone who can go back to that. So when we look at the cognitive deficits, we find that IQ is not predictive, whereas working memory and processing speed are more seen on that. The same problems are seen in ADHD also. So that is how part of the comorbidity is seen. The comorbidity of ADHD with learning disability is quite high, like it was mentioned by Dr. Jason in his talk. So word level learning disabilities are problems for phonologically representing written word, and that is the strongest predictor that you see. And phonological component is cross-linguistic, but it is more for opaque and lesser for transparent scripts. Like I told you, opaque scripts are ones where the sound to letter, what do you call, translation is not direct. Then when we come to reading, we find that the disorders are more associated with attention and executive functions, their comprehension problems, applications of strategic knowledge. So a lot of intervention for older children will change to strategic training for older children, whereas for younger children, it will be more on phonological awareness. And this difficulty in comprehension is more usually in older children who would have mastered the word level difficulties, but when it comes to text production, like the example that Dr. Jason had mentioned of a boy when he's in ninth standard started having more problems. Because in ninth standard, word generation, text generation, writing of answers and all, the more demands are higher. And there the child has got a difficulty that becomes evident. So the cognitive, linguistic, and strategic difficulties, these are seen both in oral and written discourse. In maths, you find that you have problems. You have a difficulty in mathematical competency, problems in calculation versus problem solving, and also in the processes assessed. It depends on the process also, whether you're teaching algebra, whether you're teaching fractions, etc. Like, for example, if you talk about calculus, I will not understand one word. But then you can't say that I've got a disability, learning disability in maths. But the basic processes are at what we see. So we generally stop with addition, subtraction, multiplication, division, and derivatives of that coming up to fractions, and now algebra is also included. So here also they have found that cognitive components of working memory, attention, and phonological processing are more involved. Again, mathematical development is hierarchical. It's just like the decoding is to comprehension. Here we have computation is to problem solving. But there is no one single factor that has been seen. There's also the component of non-verbal difficulty, learning disabilities that have been seen, where perceptual differences, social incompetence, and executive function deficits are largely there, but this is sort of contested also now. Writing, again, fine motor skills are there first. And for text generation, executive processes like self-regulation, organization. So when we intervene, we give them a lot of strategies for writing an answer or how to write a story. So their strategic training is more for older children with text generation problems. So when we come to the implications, it's always better that the instructions are very clear and the learner is involved in the material. So you explain what you're trying to do. You work at the difficulty level of the child. You do a lot of modeling strategies. Supervised practice is very important. And you try to promote automaticity because most of the reading goes automatically. So speeded practice is more. Try to get the child to work faster rather than to spend a lot of time. Structured, what you call engagement with real life experiences that support reading. So looking at the what you call clock on the wall, trying to read the time, reading of signboards, etc. Trying to get engagement in this also helps a lot. Comprehensive interventions for multiple practices are more effective rather than skill focused ones. So it's more based on your understanding. When you're doing a problem, you try to understand what the problems are about, how to go about, rather than focusing on specific skills of just attention or memory. And at word difficulty level also, you must focus on comprehension and automaticity. It's not just that, because I remember one of the first children that I spent about 6 months to read. This was a fifth standard boy who could not read anything other than his name without confusion. He would be able to read bat, but when you put but and bit, then he becomes confused. He will read bat for everything. But after about 6 months, I got him to start reading to a certain level. Then I gave him what we call as a cold test. I gave him a sentence to read. The sentence was, luckily for me, the sentence was, the boy ran behind the bus. And this boy, with a little bit of effort and struggle, he read the sentence. So I was feeling very proud of myself. After 5 years of schooling, this boy has not been able to read anything. Now he's reading a sentence. So I thought I was doing a great job. But then I asked him what it meant. And then he says, Paiyan odi pinnale bus. The boy ran behind the bus. So he's literally translated that, the syntax. That is when I learned about syntax and semantics. And there's a lot of more that you have to teach than just then decoding sounds and trying to associate phonological sounds to that. So when you try to teach children, you need to keep this in mind also. So instruction should be very clear, differentiated according to the child's ability level. It should be intense enough, and it should always be related to the academic content that you're teaching. And a certain amount of self-regulation where the child learns to do. So when I teach what you call arithmetic or multiplication, the child is not able to recall the tables. The child immediately writes 2 into 1, 2 into 2, 2 into 3, does repeated addition and come to the answer. So there is some self-regulation that the child follows. Also, the child can, what do you call, derive an answer by using other strategies also. So instruction should always correlate with the academic content that is there, and you try to generalize it to the general norm. All these changes that are there, even though I've shown you that there are brain areas that are compromised, their brain circuits that are compromised. The brain has got an amazing property that we refer to as neuroplasticity. So with appropriate exposure and inputs, the brain can change in its connectivity, it can change in its functional aspects. So this is what makes children change. So that malleability in children is there through a thing. So they will have with normalized changing, the changes in the circuits come to approach towards a normal pattern that is seen. And so you find a lot of activation of the dorsal and ventral systems that are there depending on the type of task. Most of these changes are maintained even after 1 year. So that is why they say that the fundamental finding from the intervention studies is that the earlier you intervene, the better. That leads to automaticity. When you intervene later, the same thing what Dr. Jason was also mentioning, whether you catch the child as early as you can, because when you catch them earlier, later they are not going to respond as well as they would when you start intervention earlier. So a lot of screening is done for children and we try to identify. As per the diagnostic criteria, you cannot diagnose a child until about age 3 because you have this 2-year discrepancy that is put into the diagnostic criteria. But a screening can identify you features of learning disability, and we start intervention for those features the moment we identify that they are present. So there are a lot of questions. Are these difficulties due to lack of exposure to print at an early stage, or is it a neural deficiency? Because you see that children who do not been exposed to print have reduced volumes and thickness of these neural circuits. And even preschoolers before school and after 1 year of schooling show a lot of changes in the structure and the connectivity of these circuits. So there's a lot of what do you call still doubts that are there. So I'll try to conclude by what I've been trying to say. So you have a clear-cut neurobiological or neurodevelopmental basis for this. There are basic brain structures that are involved, functions that are impaired. These link to certain core cognitive processes, phonological processing, all this get impaired. The core cognitive processes impact behavioral and social, so self-esteem, the child's motivation, all this do expect. Anxiety and other features also do. So the neurodevelopmental factors also impact the social factors, and it also is influenced by the environmental cortex. How the environmental context influences the neurobiology is that structured exposure to certain experiences lead to changes in the brain, and this is the basis of all our this thing. So this is what I would like to do to sum up. I've tried to maintain time as much as I can in the given time. This is a vast topic, and it'll take days. You can talk about it to try to find out. So I hope I've done some justice and given you an idea about what is the role of the brain in the learning disabled child, and how do we understand what we need to do in intervention, why intervention has to be targeted in a certain way. Thank you all.
Informative, you have described scientific component of learning disability as well as various types of learning disability and how to manage. Now I invite Dr. Susan for the next session. As we all know, Dr. Susan is a Senior Specialist Development Pediatrics, Astrokind and Astroemedicity. She has been trained from very fine institute, CMC Value. She has done her post-graduation, graduation, post-graduation, as well as fellowship from the Fellowship in Development Pediatrics from CMC Value. She has more than 6 years of experience in managing developmental children with developmental disorders like attention deficient ADHD, autism spectrum disorder, and learning disabilities. And she works with parents to ensure that children get best of the care and attention and support, and focuses on empowering children with disabilities by helping them to reach their maximum potential and capabilities. Over to you, ma'am, for the further class.
Thank you, Sitara. Thank you, Dr. Bhasi, for giving such a detailed and very simply explained processes in the brain that actually affect children with learning disability, how how the various structures in the brain play a big role. Now, what I will be talking on is this only learning disability? So what are the hidden and often unaddressed siblings or companions that are there with learning disability? So when you look at a child with poor academics or poor school performance, that is only the tip of the iceberg. There are a lot of issues under there that we need to see and solve. So we have socio-emotional issues that are there, which can be the result of learning disability, which also contribute to issues in learning. And also there are psychiatric conditions that need specific treatment. And as Dr. Jason said in the beginning, children with learning disability really struggle. They are like carrying burdens every day. And it is not just problems with learning, the whole difficulty in learning that they have, but the difficulty in learning itself causes various other socio-emotional problems like low self-esteem, anxiety, poor peer relationship, and sometimes become quite serious like depression, or there is also a biological component for that. And ADHD is known to be very linked with a learning disability. So what are the various psychological issues with learning disability? And is this because of the nature of learning disability? But like Sir had said, that there were a lot of genes that are associated with learning disability that show a correlation with ADHD. So are these psychological issues that are seen with LD genetic in nature? Or is it because of nurturing? Because we know that children with learning disability generally tend to get labeled as lazy. They are looked down in class. There are lots of family strife because of the problems with learning. Teachers sometimes do not encourage them. And overall, they end up being ridiculed by classmates. They are scolded and yelled at. And overall, they have a very difficult childhood. So these psychological issues, find out whether it's nature versus nurture is a little difficult. But the general consensus is that it is a mixture of both. That is where epigenetics comes in. So epigenetics is a rapidly emerging branch in science that is showing exactly how environment affects the genes that we have. So if we look at it, the environment affects genetics primarily by switching on and switching off certain genes. So it depends on what genes are switched on, what genes are switched off. It affects the child's abilities and their emotional and the other aspects of their cognition and development. So studies in animals and humans have shown that responsive parenting. Now, by parenting, I don't only mean the parents, I also mean teachers who are like parents for children when they spend like 8 hours in school. Obviously, this is when COVID is not there and when people are not studying from home. But when they go to school, teachers take up the role of parenting. So responsive parenting does not mean that you are a permissive parent where everything goes. It means that there are certain times when you are firm, when you are strict, but there are also times when you bond with the child, you help the child through his or her difficulties, and you support the child. So the responsive parenting causes structural changes in the brain, particularly in early infancy and toddlerhood. And this actually causes a more controlled stress response to cortisol. Now, cortisol is one of the main hormones that is elevated when we are stressed about anything. And children who have been in a bad family situation or whatever they lack getting responsive parenting. What happens is that, I'm very sorry for all these marks that are coming, not able to figure out why they are coming. Anyway, so for what it shows is that these children have a more chronic stress response. That is, the cortisol levels don't really come down to normal. And what happens when you have increased cortisol levels is that there is increase in anxiety and antisocial behavior. So responsive parenting actually decreases anxiety. There is increase in pro-social behaviors, better learning and memory. And all these actually affect the way a child learns, whether the child has an underlying learning disability or not. So what I'll be going through is a few of the psychological issues that children with learning disability face. In addition to that, sometimes, social emotional issues are what most children with learning disability face. However, they are usually hidden. When they significantly start impacting their life, not just in academic setup, but also in the non-academic areas, that is when it becomes a disorder. And so I'll be covering in brief about ADHD, about various externalizing disorders like aggression, conduct disorder, ODD, anxiety disorders, depression, and substance abuse and addiction. In addition to all this, there is another disorder that I will be covering that is called developmental coordination disorder, as this is also very commonly seen. Like I said, it is a companion or a partner in crime in children with learning disability. So the various social emotional issues, if you look at a child with learning disability, happen because, or rather primarily because they have normal IQ. So even when they are, or rather, you don't have much of family pressure from home or school pressure from school, these children themselves know that they have a problem and that they are different from others. And they tend to compare self with others already. So actually, we do not have to show them or rather point out other children to them and tell them, look at them, they are doing so well, why can't you study? Because they are already doing it themselves. And the reason, or rather the fact that they need to struggle a lot more to reach anywhere when it comes to their academics makes them feel frustrated. They have poor self-esteem and confidence, which actually moves on to the other fields also, which leads to poor peer relationships and poor social skills. And they finally actually end up having a situation where we call learned helplessness. This is where they are continuously trying to do something, but finally, because they are not reaching anywhere, they just give up. And then their motivation decreases to even try. And all these issues that they are facing, because adults are not aware that they are facing these issues internally, they end up getting scolded by parents, they are called names, they are humiliated, they are made to, at least in olden, or rather when I was studying and all, I remember there being instances where they were called out for not being able to read well and were put out of classes and all that. So all these kind of behaviors from the adults in their life actually worsen the social emotional issues that these children have. If you look at a child with a learning disability, he starts off with a disadvantage. And in the race of life, it is like they are dragging a heavy iron ball that has been chained to their leg and trying to run a race. And comparing them with children who naturally can run faster is, I would say, it's just quite cruel. And they hide their anxiety and their depression when they can and pretend to be fine. And so this is what Sir also said is like a hidden disability. It's a hidden issue that we have. So parents and teachers need to be aware that this is there in these children. So if you look at it, this is what I was telling in brief. A child with a specific learning disability, by virtue of them having normal IQ and being aware that they have difficulty itself, causes a low self-esteem. They're frustrated, they're anxious, they face rejection, isolation, and because of their neuronal circuitry or the differences in their neuronal circuitry, they mature late. They are unable to identify with the emotions of others, and so may actually act out. And because these symptoms, or rather these feelings, are not verbalized by children, they present outwardly as school refusal, aggression, anxiety. They are withdrawn, poor peer relationships, psychosomatic symptoms like migraine, headache, headache, stomachache, nail biting, bedwetting, antisocial behavior, depression, suicide ideation are all things that happen. So again, just reiterating what Dr. Jason said, always remember, no child performs poorly on purpose. So any child, particularly the younger children, if they are performing poorly, there is a reason behind it and it needs to be evaluated. They not necessarily have learning disability, but there is a reason. There are multiple styles of learning, actually, if you look at it, and there are multiple intelligences. Academic intelligence is just one. And always remember that if a child can't learn the way we teach, maybe we should teach the way they learn. So what exactly are these multiple intelligences? So there are around 8 types of intelligences that are commonly known, and each intelligence can be accessed through a particular way. And children learn actually through using what intelligence comes to them naturally. So it is not just through language, which is writing, reading, and listening, which is what you call verbal linguistic intelligence. But maybe they are naturalistic, so they take a hands-on approach and they learn through experiences. Maybe they are visual spatial, so they learn through pictures, diagrams, flashcards, drawing. So, or maybe they learn by discussing with other people. Whatever your child's strength is, that is the way they have to learn. Doesn't always. So this is one way of decreasing their anxiety. Another important thing that I want to tell is that always remember that be kind when we talk to children, because the way we talk to our children becomes their inner voice. That is what is going to determine how much they think of themselves when they grow up. And sticks and stones may break bones, but words can shatter souls. So words matter. Be kind to your own child. Be kind to the children that you see, because you do not know that the struggle that they are going through. For that matter, be kind to everyone you see. You have no idea who is going through anything in life. Now, coming on to the other disorders that really need intervention. So we call it a disorder when children have problems that make a significant impact in not just their academic lives, but also in the other areas, non-academic areas, like in socialization, in at home, in playground. So the most common disorder that's seen is attention deficit hyperactivity disorder, and it is the most commonly associated with specific learning disability in around 60 to 80% of children. This is a genetic, neurobiochemical, and developmental disorder, and it is characterized by hyperactivity, impulsiveness, and short attention in more than one setting. So I have parents come to me saying that the child is extremely brilliant in everything else, but the moment the child has to sit and study, becomes fidgety, is very restless, will run away, will do anything. But you give her a puzzle to do, she will sit there for hours together doing that puzzle. That is not ADHD. That is avoidance behavior from a task that is difficult for them. So you should definitely have it in more than one setting, which is non-academic. And the need to identify this is because without intervention that benefit ADHD, it is difficult to offer remediation for specific learning disability. So there are 3 types, like Sir had briefly said. We have a predominant hyperactive impulsive type, where the child is jumping off the walls and is generally all over the place. Then you have a predominant inattentive type, where they seem to be imagining something, or in the midst of doing something, they just go off. They lose track of what they're doing. And the third one is a combined, where you have both features. So there are clear-cut diagnostic criteria to diagnose this, and only if they fulfill them do we say that the child has ADHD. Not all children with hyperactivity and inattention are ADHD. Now, there is a general misconception that children with ADHD are not able to focus on anything. But the fact of the matter is that they actually pay attention to multiple stimuli simultaneously. It is difficult for them to focus on one thing. So, for example, now while I am talking to you, I have the screen in front of me, which is my primary area of focus. But I have people sitting around me. I can hear people moving around. So, but I'm able to focus more on what I have to speak rather than getting distracted by the stimuli around me. So that inability or that difficulty in focusing is what actually is the main issue in ADHD. They also have poor executive functions, like these are the various executive functioning skills that a child needs to be able to plan, to be able to organize, inhibitory or self-control, so that you don't just run into the middle of the road, but you're able to wait, time management, flexibility, attention. So all these are lacking, or not that they're absent, they're deficient in ADHD and also in children with specific learning disability. There is definitely an overlap in the genetic causes for ADHD and specific learning disability. So that is why these both occur together. So again, as I said before, it is considered significant only when it begins to affect either the performance in school, or it affects social relationships and friends, or the behavior at home. And the diagnosis is made. We have follow the DSM-5 usually to make a diagnosis of ADHD, and there are 9 features that belong to hyperactive, impulsive, inattention, and you should have at least 6 of 9. So like I said, it's a formal diagnosis that is made, but the salient points, other features should start early. Sometimes I wonder whether I have features of ADHD, but I know that I didn't have it in the childhood, so it is not ADHD. So when you go through the questions for ADHD, you might actually wonder whether you yourself have, but the features should have started earlier. Must cause a real handicap in at least 2 settings, and it is a continuous problem, not just a response to a temporary situation. Like, for example, if there's a death in the family, or and the child is worried and is not paying attention in class, that doesn't mean that the child is inattentive or has inattentive type ADHD. It is a temporary situation. Okay. Now, like I said, not everything that is hyperactive or inattentive is ADHD. There are various mimics of ADHD. So, an unexpected sudden change in a child's life, particularly during this pandemic situation, you see many parents saying that my child has become very hyperactive, is not paying any attention. This is definitely a sudden change that has happened that has totally disrupted the child's life. So they can mimic to have ADHD. There can be undetected seizures, temporal lobe seizures, absence seizures can mimic ADHD. Hearing issues, visual difficulties can also cause a child to be inattentive and can mimic ADHD. Anxiety, depression, and again, underachievement caused by SLD, like that first one child that I told you about, where the child was very hyperactive, very inattentive the moment something academic was given. So this can also mimic ADHD. There is also another disorder that is called auditory processing disorder that can mimic ADHD. So what exactly is this? This is where a child has difficulty processing and understanding any sort of verbal instruction. Or it may be they get upset when they are in a noisy area, they prefer silent places because their brain gets overloaded by the auditory stimuli and is not being processed normally. These same children, they are much better visually. So when you give them a visual task, they are able to pay attention, they focus on it and they do it beautifully, or they are able to follow instructions when you give them a visual prompt also. But it is auditory inattention that is there. This can also be misdiagnosed as ADHD when it is actually a processing disorder. Now, role of electronic media exposure. Does it actually increase ADHD? Now, this was a very interesting study that came out in 2012, where there was a set of newborn mice that were overstimulated using cartoon songs and light simulation, which was similar to that of a TV. And what was shown was that in the 1 to 2 months after the born mice were born and they were stimulated, even after the stimulation was stopped, they continued to show high levels of risk-taking behavior, high levels of hyperactivity when compared to the other mice. So overstimulation is something that does alter, again, like I said, epigenetics comes in. It does alter the neuronal transmission. It does causes changes in the neuronal wiring in the brain. And these children do tend to be a little hyperactive. But again, what we see is over the years that we see children who have been exposed to electronic media from a very young age. Moment you stop it, they make dramatic change. Their outbursts decrease, their risk-taking behavior decreases. So there is whether there is actually a long-lasting effect of this, we will need to keep in mind. But everyone with small children, please do not expose your children much to the electronic media. Now, the externalizing symptoms of aggression, oppositional defiant disorder, and conduct disorder, most of them have coexisting ADHD. In fact, in a study, it showed that when we looked at these symptoms in children with learning disability and without learning disability, once the factor of ADHD was taken into consideration, these symptoms were equal. So opposition defiant disorder is generally seen in children less than 6 years of age, and they tend to be very defiant, and basically it's there in the word. They oppose their parents. If parents tell to come here, they go there. They say to sit down, they stand up. They show some defiant behavior. This is actually normal in the toddlerhood, 2 to 3 years of age. It is part of their natural development. But when it persists, it can be it may be a sign of an oppositional defiant disorder. Conduct disorder is for children older than that who tend to have antisocial issues. They do not obey rules. They do not respect authoritative figures and all that. So again, studies, or rather many people have wondered whether this is actually true comorbidity or is it resulting from the emotional consequence of having specific learning disorders. And in all of these situations, learning problems precede behavioral issues, and they can have abnormal language processing and working memory deficits. Okay, so anxiety, again, it's a little bit of a vicious cycle. You can have anxiety because of learning difficulty, and anxiety worsens learning difficulty. So it kind of goes round and round. So how do you figure out whether a child has an anxiety disorder? It's good to differentiate whether there is a reading or performance anxiety alone versus generalized anxiety. So what are the symptoms of anxiety in children? They can have separation difficulties. They would always be clinging on to their parents, school refusal, phobias and fears. So phobias are excessive, sometimes even irrational fears of things. They can have panic episodes, which is sudden excessive fear, which is accompanied by sweating, increased heart rate, feeling of giddiness, dizziness, nausea. They tend to avoid social situations, or they tend to isolate themselves. They can have eating and sleeping difficulties. Few of them develop obsessive compulsive traits also as a method of alleviating their anxiety. They feel that on doing the same thing or on thinking the same thing over and over again, they feel less anxious. And again, physical symptoms like headache and stomachache. So anxiety disorders are the second most common behavioral disorder that is seen in children with specific learning disability. You have generalized anxiety disorder where they are anxious no matter what the situation. You have separation anxiety disorder where they are very fearful of being separated from their parents or their caregivers. They have fear. They are worried about death of their caregivers. Can have phobias, again, like I said, where going to school becomes a phobia because of something that they have experienced, and then they just don't sleep at night. They have excessive fear towards it. Panic disorders, again, the panic attacks that happen without any known cause. This pandemic has again made two more disorders quite common now. You have the post-traumatic stress disorder, where children who have been indoors for so long are kind of scared to go out. The moment they are out, all they want to do is get back in. They are worried as to when is COVID going to attack them. And anytime they go out as a family, they just want to get back in. So this has kind of come out like a post-traumatic stress disorder. You have obsessive compulsive disorder also, which is also now becoming more and more because of the obsessive need to use sanitizers and to keep a distance, and also more of these disorders are starting to crop up now. Now, depression is the third most common disorder. It is seen in 5 to 20%, and adolescents are more susceptible, primarily because that is when peer acceptance is most craved. Children who are younger do not mind being around with adults as much, but when you're adolescent, you want people of your age to pay attention to you, to like you. It is seen more in girls. There is a genetic or biochemical predisposition. So if your parents or if someone in the family has had a history of depression, then it is more likely that the child can have depression. And the various, like I said, epigenetic factors that can precipitate depression are chronic stress due to the academic problems, lack of success, failure in friendships, family issues. And generally, children with learning disability tend to have impaired emotional processing. And that is also another reason why they very quickly go into depression. So the symptoms of depression are more or less like what we see in adults, where there's depressed mood during the day, particularly in the morning, change in personality, feelings of persistent tiredness, feelings of low self-worth, excessive guilt, loss of pleasure in previously enjoyable activities, significant weight loss, inability to sleep, thoughts of death, suicide. Substance abuse is the next thing that we do not really know how many children with learning disability go into substance abuse, but we know, looking at people who have had substance abuse, that up to 60% of them have an underlying learning disability that has been undiagnosed. They have similar risk factors as low self-esteem, loneliness, peer pressure, faulty executive functioning and decision-making, and definitely the risk is higher when there is coexisting ADHD present. Developmental coordination disorder is when the motor coordination is below expected for his or her age, and they're generally labeled as clumsy. They tend to trip over things, spill things, drop things, not able to perform in fine motor activities like knotting, not able to skip. So this is also again called a disorder when it interferes with academics and the activities of daily living, and this is also called as developmental dyspraxia. This is commonly seen actually in children with learning disability, and this how to manage it will be dealt with in detail by Anju, our occupational therapist, tomorrow. So now that I have gone through this whole list of things, why do you really need to know this, and what difference does this make? Knowing that a child with learning disability, just by remediating their problem, by sending them for remedial training, it's not the end of the story. There are a lot of hidden emotional and behavioral issues that these children have, and these need to be addressed for them to become successful, resilient adults contributing to society. So I'm just going to quickly go through, I know I'm running out of time, but I will quickly go through a few steps that parents can do at home itself to modify behavior such as hyperactive behavior and improve attention at home. So have a structure to the day, particularly in this pandemic time, because children in the current scenario, most children go to sleep very late, wake up whenever they feel like, or if there is online class, they will wake up just before the class. But the sleeping times and all are very haphazard. And having a structure to the day helps children with learning disability especially get organized, because as I've shown you earlier, organizational skills are deficient in children with learning disability and ADHD. So sleep by around 9 p.m. The reason why I say 9 p.m. is that if there is a circadian rhythm to cortisol hormone in our body. So for the ideal circadian rhythm to happen, 9 o'clock is what generally most people agree on, because it takes the brain 2 to 3 hours for that regulation to start happening. So have a daily schedule. Physical activity is very, very, very important. Again, particularly during this pandemic time, it is one way to again foster attention and decrease hyperactivity. We've had a lot of questions from the group while during registration process as to what do you do for a hyperactive child. So these are all things that you can do. Task-oriented physical activity, because then they also have to pay attention to what they are doing. Again, restrict e-entertainment. Online learning has become online, so entertainment should become offline, because like I said, it does affect your attention span and your hyperactivity. So this is generally what is recommended. Gadget use can be used as a reward if needed. Again, not very keen on it, but if children definitely need to or are demanding gadgets, you can use it as a positive reinforcer. Sensory play is something that is again helpful for children to again calm themselves down, and family games especially. Play together as family, because that promotes a sense of acceptance. Children share a lot more when they are happier, and it helps ameliorate most of the stress-induced academic-related difficulties that these children have. Work on a fun project, which is please not academic. Many of them, like we said, have multiple intelligence. So do DIY things at home, experiment with things, start a garden, rear a pet, something different so that again the child can contribute meaningfully. Now it's a time when it may be difficult for children to go out and play with friends because of the pandemic situation. So work on something that is not academic as a family that they can do so that their creative side comes out and it lowers their stress level. Again, FaceTime with family and school friends because people need to feel connected, and it is not just studies that eventually matter. Interpersonal relationships are very important. Involve the kids in household activities. Even from as young as 1.5 to 2 years of age, children can be very actively involved in many household activities. Hug your kids more. That's something that I kind of tell all parents, because when children go to school, there are a lot of physical contact that they have with other children that is missing in a home setup, especially when parents are working and when a child with learning disability already is stressed out with exams or stressed out with the normal academic processes. Hug your child. It really helps regulate the nervous system. So do that. Okay. Be kind again. Like I said earlier, words have power. Empower them in non-academic fields. We know of many famous people who have done extremely well despite having dyslexia. Actors like Tom Cruise and Abhishek Bachchan, movie directors like Steven Spielberg, scientists like Edison and Albert Einstein. All these are famous people who had dyslexia. So just because your child has a learning disability doesn't mean that they are going to be backward in life. Definitely extracurricular activities are needed to improve their social skills. Identify their strengths. Pay attention to the 8 intelligences that we have. Find out what their strengths are. And support groups. Even for children, I would suggest children with learning disabilities, if they're going to a remedial trainer, it will be good to get in touch with the other children who also go to the same remedial trainer, because they understand each other and they can support each other. Professional interventions are mostly when they have disorders, but can be sought at any point in time. We have psychotherapy, which is cognitive behavioral therapy, which plays a big role in anxiety and depression. Supportive psychotherapy, interpersonal psychotherapy to work on relationships and to help develop their organizational skills. Play therapy, talk therapy for children. Family counseling is very important, because families play a big role especially in, like I said, in forming a child's inner voice. And that is it is not just IQ that is important, EQ is also important. Emotional quotient, the resilience to be able to come back up when life puts you down is something that is very important, and that children learn from their parents. Family counseling, psychoeducation is very important. What is the role of medications? It does not help in learning disability, but when there are disorders, sometimes we do need medicines. So, but this is also, it is not a one size fits all. There needs to be an individualized treatment plan, and it's given only after proper assessment and diagnosis is made with the consent of the parents always. In short, I'll just say that learning disability hardly ever exists in isolation. We need to pay attention to the social, emotional, and behavioral aspects. And when functioning is impaired is when it's called a disorder, which needs targeted intervention plus or minus medication. Medication doesn't alter the learning disability. And always remember that no child chooses to do poorly in school. Environment and parenting play a huge role in the child's life. So be mindful of your words. They become the child's inner voice, and seek for strengths always, not just difficulties. Now, I will just end by playing a small clip which kind of summarizes what has happened today. I hope you watch it and enjoy, after which we shall start the question and answer session.
Your brain is amazing, and nobody else has one quite like it. Although everybody's brain looks the same, they all work differently from each other. Just as we all have different color skin, hair, and eyes, we all have a brain that's individual to us, like a fingerprint. We have different personalities, tastes, strengths, and weaknesses. Our brains can even see and understand the world in different ways. One of those ways is called dyslexia. which affects how the brain handles information it sees and hears. Dyslexic people may find it difficult to match letters to sounds and to remember how to spell words. They may even see letters moving around when they're reading. They might have trouble telling left from right. Remembering lots of instructions can be especially hard. They may need more thinking time to remember the right word.
Chicken! No, wait. Duck!
As well as memorizing sequences. It may be difficult for them to hold a pencil and to write by hand. Even organizing themselves can be difficult. But everyone with dyslexia is different. It can affect how people feel about themselves. When they struggle with a task that other people find easy, they may feel frustrated, angry, or sad. Some dyslexic people try to hide their difficulties because they are worried about what others will think of them. However, thinking differently can be a really good thing. A person with dyslexia may be your brain for it. It may be difficult for even organizing themselves can be difficult. But everyone with dyslexia is different. It can affect how people feel about themselves. When your brain is dyslexic people try to hide their difficulties because they are worried about what others will think of them. However, thinking differently can be a really good thing. A person with dyslexia may be very good at seeing patterns and solving problems, imagining and rotating objects in their heads, telling stories and making people laugh, taking things apart, understanding how they work, and figuring out how to put them together again. Inventing, drawing, painting, and making things. Seeing the bigger picture. Dyslexic people can do a lot of things. They just might do them in a different way to how others would, and many of them have even become famous for it. There have been many famous dyslexic inventors, writers, scientists, business people, astronomers, paleontologists, actors, cooks, singers, artists, architects, and so on. Dyslexic people have changed the world. See dyslexia differently.
Sir, Jason sir. Then I'm
Dr. Basi. Hello, sir. Hello, Basi sir is there? Hello. Hello. Basi sir. Dr. Basi sir, are you there, sir? I think we are not able to connect with Dr. Basi sir, as well as Jason sir. Susan? Will
Okay, will you unmute here, sir? We are not able to unmute. You can probably do.
Yeah.
Yeah, sir is here. Sir, is it audible?
Yeah, I'm also here. Basi,
Okay. Okay, sir. Okay, sir.
Yeah, you didn't unmute us, so that's why.
Okay, sir. So we have few questions for you. The first one is how to distinguish whether a child is having dyslexia due to brain issue or whether it's due to lack of stimulation. That is the first question posted by one of the participants.
Who is this for? See, if it is a brain issue,
yes, sir.
Then there are certain conditions which you must remember could cause learning problems. Because learning disability is generally clinically the child is absolutely normal. You don't find, except some soft neurological signs, you won't find much of abnormalities in this child. But if it is a neurological issue, invariably there will be maybe a chromosomal anomaly like a Down syndrome or Angelman syndrome. There are certain typical features. There will be a cerebral malformation like a polymicrogyria or hydrocephalus. Which there may be neurocutaneous syndromes like tuberous sclerosis, X-linked syndromes like Fragile X-Rett syndrome, convulsive disorders like LKS. So there are a lot of conditions which come into mind. There will be metabolic disorders, intrauterine infections, so many things. IUD like hypothyroidism is something that we must not miss. So these are conditions which you must keep in mind when you're dealing with a child with learning disorders, because if it is a neurological problem, there are totally different treatments required. Here you are talking about plain specific learning disability where there is a normal brain, except some areas where the skills for learning are affected. Those children will not have many signs like, you won't expect them to have many clinically distinguishable signs, including syndrome. If that is what the person asking the question means.
Okay. Yeah. Thank you, sir. And there's another question, like how is CogMed used, and is there any other tools for working memory training and academic training in children with learning disabilities? This is for Basi, sir.
I'll take that question. CogMed is largely used for training for working memory deficits. It's an online tool that is available. I think Pearson markets that. And it is quite comprehensive. It covers various aspects of that. It is self-pacing. So you go on from one difficulty level to another difficulty level. There are some other tools also. I think there is something called as Rewire that has been developed by a team in Bangalore. Dr. Keshav and his wife Akila, who works a lot with learning disability, they have developed an online app for training, but I don't know more information about that. There are other tools like Lumosity and all that are available, which are available online also. There are a lot of, but for learning disability specific tools for language remediation, I'm not aware of.
So what about any tools to examine whether the phonological route versus the visual route is impaired or not? You had mentioned about the different domains to be checked for word processing and comprehension. So would you suggest any assessment tools that can be used?
The only tool that comes into mind is the dyslexia assessment for languages of India, the DALI tool that has been developed by the NBRC in Delhi. They have done some work, and they have done a lot of studies that are working on these two streams also. But I don't know whether those tools can differentiate whether it is a word recognition. Most of that will be picked up when you do the remediation component. So irrespective of whether it is, you're not going to deal with one particular aspect or try to differentiate it that much. DALI is Dyslexia Assessment for Languages of India. DALI, that is a tool that is developed by the National Brain Research Center in Delhi.
Okay.
And if you type out DALI or Dyslexia Assessment for Languages in India and search on Google, you will go to their website. and they do training programs for teachers, etc. We had conducted a training program in our center, I think last year, in 2018, when we did the conference on cognitive and clinical neuropsychology. We had done a training workshop on that. They do training programs also.
Now it's for Dr. Jason. Sir, at what age a child should be taken to the analyst for a depression disorder caused by this learning disability, if we are suspecting that?
No, depression is not uncommon even in small children. And, depression, you recognize depression if there's a change in behavior, if the child is become very irritable, sleep is disturbed in an older child, adolescent child whose sleep is disturbed. There's a change in his friends. There's a change in the way he reacts to you. And, it's very difficult the subtle changes of depression are very difficult to recognize because younger children don't feel so sad, but adolescents can feel sad and miserable and they feel useless. The feeling of uselessness, anytime the child says he wants to die, thinking of suicide ideation. These are all so the danger signs, red flag signs of depression are a family history of major psychosis, previous histories of depression, previous history of drug ingestion and suicidal attempts, and hallucination. If there's a child has hallucination, it's a very, very bad sign. So these are children who require psychiatric help. But if it is minor depression, which with mood changes and sleep disturbances and all that, they can be treated with medication and some psychotherapy. Medication, we use fluoxetine or fluoxetine, which are very safe at smaller doses, and they can help tide over the problem while you are giving them ways of improving their self-esteem and self-awareness. It is not
Thank you. Thank you, sir. Now, about ma'am. Sir, one more question. Is there any tool that can be used as a screening tool for assessment of specific learning disorder in OPD? Any tool which we can use in OPD to decide whether it is a learning disorder or not?
There are teacher screening tools which are available, which the Indian Pediatrics suggests that teachers for failure in a class, failure in a subject, last 10th centile of the school of that class, and difficulty to teach. These are all conditions where situations where you must pick up these children for assessment. There's an easier screening method than doing a tool, which there are teacher scales which are available, which are recommended by the Indian Academy of Pediatrics and is there in the document which is published in Indian Pediatrics.
Yeah, in a clinical OPD, I think it is more practical to identify children who need to be evaluated for learning disability rather than relying on a screening that has to be done in the OPD because of the time constraints that are there.
Because the thing that we look for is these, I told you, anxiety, tiredness, psychosomatic symptoms. These are all, any child comes to the OPD, we check about their educational history. How is he doing in school? Because the parents don't think that doctors are the persons who have to take care of children's learning problems. It's the teachers, the educators. So that is an issue therefore we as we tell pediatricians to check out their education history. How do you do in class? Does he have a problem there? When you find any psychosomatic symptom that the child has.
Yeah, and there are some screening tests that are already available on market. There is a dyslexia screening test, the Shavitz dyslexia screen. All these are short screening tests that are available. And I think they are marketed by Pearson, the same organization that comes out with CogMed. There are screening tests that are there, but the application of that, the circumstances in which you want to do a screening. So if you have a large number of children and then you want to identify people whom you need to narrow down to a smaller pool, then a screening test would be more. But when
try Vanderbilt. Vanderbilt can be tried. Vanderbilt can be used as a screening tool.
Vanderbilt will be more.
So there's another question. There's another question, sir. Can I say that to Dr. Basi, sir? Sir, should the child learn to converse the language before learning to read and write?
Not necessarily, because if you look at schooling right now, they are introducing second language, they are introducing Hindi, all these at times, and the child learns to read straight away from the alphabet. So it is not necessary that the child converses, but if you suspect a child is having a learning disability, then it is always better to stick to one language and do remediation in that language, and that should be preferably the language the child is conversant in. Now, with the new education policy till about 5th standard, all training will be in the mother tongue. So, and English, if it is introduced, is going to be introduced as a subject. So, it is not mandatory that a child should be able to converse in a language before they learn to read and write.
Thank you, sir. So one more question. How can we identify the learning disability with a neuroscan of the brain? Can we do that?
I am not aware of that. Maybe I think Dr. Jishan should be able to. I'm not aware that any scanning can identify learning disability.
No scanning at all. These MRIs, functional MRIs, are used only for studies. It is not for testing children with learning disabilities. There's no scan.
So there's a question for Dr. Jason that some children may come up with depression, whether it is due to depression disorder or whether it's due to underlying learning disability. So how to distinguish?
No, I mentioned about depression, how you pick up depression in children. And so when a child with learning disability has a family history of psychosomatic disorders and they goes into those symptoms that are already mentioned, then you must consider depression. These children are, endogenous depression and psychosis are different. So if there is a family history of psychosis, if there is repeated suicidal ideation, hallucination, sleep disturbances, you must consider this child as depression and treat accordingly.
And thank you, sir. We have some more doubts. I think it was clear during the presentation. That is regarding the terminology of whether it's learning disorder or learning disability. It was mentioned that according to DSM-5, it is specific learning disorder. Previously, there were various other terminologies. So we'll move on to a question to Dr. Susan. Ma'am, what suggestions do you have for teachers who think that all is done after referring children with learning difficulty to a resource teacher? So how will their attitude support a truly inclusive school?
Okay, so resource rooms are nowadays becoming very common in schools, and it is a good addition for the fact that child is able to get one-on-one attention, and remediation methods can be used in the class. But the role of a teacher, especially a class teacher, is much more. For true inclusion to occur, the child should be made to not feel like an outsider and who will just go for some remediation classes and come back. He should be actively made to be involved in the activities of the class. So even if the child is going out to the resource room for certain classes, maybe the teachers can give the child a position of a responsible position in class when he is there in the class, get the child to actively participate with others. So actually a lot on what teachers can do will be covered in detail by a wonderful teacher, Mrs. Anita Satyan, tomorrow. So she'll be able to tell how practically teachers in class can can do wonders for a child's self-esteem. Because like I said, teachers are your second parents. I'm sure most of us have had scenarios, at least I know I've had, where I would give more weight to what the teacher says than what my own parent says. I fought with my parents saying that, no, my teacher told me this, you are wrong. So teachers are considered very, very important for children. So the way you regard your child with an issue is what the other children in class are going to follow. So just sending them off to a resource room doesn't mean that your job is over. While the child is in your class, you have it's your responsibility and it's your duty to make the child feel included in the classroom. And with a little love, actually all these children need is love and acceptance. And with that, their entire futures change.
Yeah, I want to add that, teachers should take responsibility for every child in their class, know everything about every child in the class. And one thing that they must try and find out is children with empathy, who can sit next to these children with learning disability and help them out. That's a very important activity for a child, for a teacher, to find children who can help children. Those children who are good in class, who are good at studies and can help other children. They should be sitting next to these children, and they could be a great help, because peer interaction, peer education is something that one-to-one, if one-to-one teaching cannot happen, that peer education would help a lot. And teachers should never, ever mark in red pencil. Should not, throw away the books if it's wrong, everything is wrong. Should not make the child who cannot talk stand up and say and read, who has a difficulty with reading. So whatever the child has difficulty with, the child should not be made to do in front of the rest of the class. So those things, things to make the child feel good. Finding out their strengths, putting up, if he's good at painting, take that painting and put on the notice board. So, and if he's good at singing, make him sing in class. So something that makes the child feel that he's good at something. So that gives them the child a feeling of improved self-esteem. The teachers have a great role to play in ensuring that these children do well through their life.
Thank you, sir and ma'am. There's a question from another participant. I'm a teacher. I had seizures, fits. It happened at my 6th standard onward. Now I'm continuing medication. My question is, does my child will also have similar difficulty? My delivery was complicated. I had one child before and she passed away, and brother has mental depression. So
see, if you have a father or mother has seizures, there is 1 in 20 chance of a child developing seizure by the age of 40. Those are studies that show that. So there is all seizures are not genetically, they're not transmitted genetically. It's not hereditary, but there is a proportion that is hereditary. And this is the statistics. If you have a mother or father has seizures, by the time the child becomes 40, the chance of 1 in 20 of having seizures is there. But it's not it's not a very strong thing, but 1 in 20 is quite a bit for the particular child. If you get seizures, it's a problem. So this is the statistics that we need to know. And depression, if the mother's brother has depression, there's again a chance of the child developing. It's all most of it is hereditary, and many of these conditions we need to understand which are hereditary, and therefore they should be, these are high risk children who need to be assessed properly at regular intervals.
There's one more question. A 5-year-old boy, he is able to do all the activities on his own, but is unable to speak independently while he can sing. What is this condition known as? As a speech language pathologist, I would advise them to seek a consultation with an SLP for the language delay. And in addition to that, Dr. Susan can suggest.
If a child can't speak but can sing, actually, my first red flag will go up for autism. But I definitely need to know a lot more about what the child's other social interaction is, what are the child's other, now, what all has the participant said that the child can do?
He can do all the activities on his own. Only speaking is affected. And he can sing as well.
Okay, so again, all the activities, like we see a lot of children who come to our OP. Children at 2-3 years of age will know the alphabet inside out, will know the numbers inside out, but again, may actually end up doing a lot of their things independently, but they can't communicate. And it is not just speech, communication is what we need to look at. So these children will just keep singing, but will not communicate in any way, be it verbal or non-verbal. So without getting any further details, actually, it's difficult for me to say what it may be. But I would, with a child who sings but doesn't speak, autism is on the top of my list that we'll need to look out for.
Yeah, I agree with that there should be some additional assessment that needs to be done for this child before one can arrive at a decision. I think it will be important to look at the early development of speech also. So early in around, say, the babbling, single word presentations, development of speech, and then whether there's any change in language. And now at 5 years, the child doesn't speak. I think that information is also pertinent. So detailed evaluation is, I think, necessary in this situation. Thank you.
So one more question. Due to the pandemic, now most of the classes are on virtual platform. So how can the virtual teaching be helpful for fostering better learning in students, or how can the teachers make it better?
Maybe I'll just give my thoughts on this because I have. One is that virtual platform for teaching is not suitable for young children. Say below the class of 4 or 5, children will not have the understanding about the need for sitting there, paying attention to what the teacher is saying and all that. So young children, especially preschool, first standard, second standard, the teaching is just, the parents, I think, put in more effort than the children in that, because that modality of teaching is not suited for those children. If at all you need to use a virtual platform for teaching, we don't have any other option, then the mode of delivery has to change. It has to be more in terms of things the child can enjoy seeing, using of animated characters, actual scene, demo sessions, things like that should be more, rather than a teacher sitting there and talking to the child on the screen. Physically, if the teacher is present, the teacher is able to engage the child's attention, interact with the child, especially the younger group. But this is not possible when you do it on a virtual platform. For older children, where they understand the need and they know that, okay, they are supposed to learn something from this session is meant for that, I think a virtual platform has certain disadvantages and certain advantages also. The advantages will be that you can start involving blended teaching methods. It can be self-paced. A lot of self-paced teaching can be done for older children, whereas this is not going to happen for younger children. My personal experience I've seen is that the classroom, the children get very bored. Younger children, they just get up and they just walk off. They throw away their headphones and you just can't do anything with that. But whereas if I put something like on a YouTube video where there is some teacher who's teaching numbers and this, there you see that the whole format is totally different. There are a lot of animated characters, there's some sing song, the teacher is practically singing, and the delivery is entirely different and the child's response is also different. So I think these factors need to be taken into consideration. Those are just my thoughts. Thank you.
Thank you, Dr. Bhasi and Dr. Jason, for this very interactive and very informative session. And I want to specially thank Dr. Bhasi for participating in this webinar and for all the the knowledge you have given us today. And sir, as a token of our appreciation, sir, we have a small memento for you, which we will courier to you. This has been made by an association called Takshan Creatives. So this is a subsidiary of Urja Foundation, which works at creating employment opportunities for differently abled children. So we are very thankful, sir, that you were able to join us for this webinar, and thank you so much for giving us your expertise. We may continue to send you questions that come in from the participants through the WhatsApp groups that we get. And we're looking forward to further association with you in the future.
Sure.
Thank you, Dr. Basi, from my side too.
Yeah, it's my pleasure. Thanks a lot.
Thank you.
I've never had an opportunity to work in Kerala. So that is something that I always felt. So any opportunity to get involved in any program that is there, unless there's something pressing, I always say yes. It's always my pleasure. Thank you very much.
Thank you.
And that comment is very touching. Thank you so much for that. I've sent you a mail. You read it and you can send both the things.
Sure, sir. Thank you so much, sir. And I would like to thank all the participants who very actively participated in today's session. We will meet again tomorrow at 10 a.m. Lots of questions that haven't been answered yet, but that is because those queries will be addressed by tomorrow's speakers. So hoping to meet you all tomorrow at 10. Good evening and have a good day.
Yeah, thank you very much.
Thank you. Thank you so much. Good. Well done, Susan and team.
Thank you all so much.
Thank you, sir.
കുറേ ക്വസ്റ്റ്യൻസ് ഉണ്ടായിരുന്നു, കുറെ ക്ലാരിഫിക്കേഷൻസ് ഉണ്ടായിരുന്നു. നല്ല ഈ രണ്ടാമത്തെ